Well, good morning, everybody. It's a pleasure to be here, and thank you for the invitation to speak at this important event. I'm going to talk about patient safety and healthcare-associated infections and the HPAs, the Health Protection Agency, that's the national public health body, our role. And in so doing, I'm going to draw on my own experiences over the last 4 years at the Health Protection Agency and my roles including as medical director, but I also oversee all our work on healthcare-associated infections, and I want to give you a bit of a flavour of how we're involved. Now, the HPA has a limited direct involvement in patient safety and healthcare-associated infections in hospitals, but it has a substantial indirect involvement. And so what I'm going to try and do is provide you a framework, some background about that indirect involvement, the national role that does feed into infection control in hospitals, so that sets the scene, hopefully, for the rest of the day and later discussions. So in my 25 minutes or so, I will give a little bit of historical backdrop. When I get to the HPA's role in infection control and HCAIs, I'm going to focus on 3 areas: surveillance, prevention, and control. But before we get into that, why are healthcare-associated infections important at all? Well, in my assessment, there are 4 reasons. We're familiar with those. They harm people, they kill people, they cost a lot of money, and they create adverse publicity, some of which is adverse and some of which is rather strange. And in response, over the last 10 or 15 years, we've had a huge amount of policy interest and attention to infection control and healthcare-associated infections. Now, I went through and tried to find all the policy documents that we've all been subject to over the last 10 years, and let me just give you a little bit of a flavour. In the last 10, 12 years, we've had cleaner hospitals and cleaner care. We've had NAO reports. We've had Chief Medical Officer attention, that was Sir Liam Donaldson. We've had Winning Ways, Saving Lives, the Health Act and the famous Code of Practice. And we've had Safety First and inevitably more. There's been a lot of policy attention over that. This took me a long time to get all of those on one slide and keep the titles visible. There's been a lot of policy attention. We in the HPA work closely with the Department of Health, but we are, at the moment, not part of the Department of Health. On top of that, we've had 3 important Healthcare Commission reports, which people will be familiar with: Stoke Mandeville, Leicester, and Maidstone and Tunbridge Wells. So there's been a lot of recommendations coming out of that. So that's the backdrop for the last 10 or 15 years. Before I go into the HPA's role, though, I want to just give you a little bit of a historical flavour, because, of course, infection control and healthcare-associated infections is not something new. This is a little bit of the historical backdrop, and taking you through from microbes to the first infection control policies. Now, in the top left-hand side here, this works, yes, Anton von Leeuwenhoek was a Belgian draper who first used a microscope and noticed bacteria underneath the microscope. Semmelweis, I'm going to come back to in the antiseptic hand wash in a moment. Florence Nightingale, mid-19th century, and hygiene in field hospitals, Pasteur and germ theory. And you can see down the bottom here, this is the historical trajectory from miasmatic theories of disease to germ theory of disease at the end of the 20th century. Joseph Lister, and in Scotland and elsewhere, and his famous antiseptic surgery and the carbolic spray, spraying the operating theatres to get rid of the miasmatic pollutants that harboured infectious agents. And we have Robert Koch, and of course the link between bacteria and disease, TB in particular. But I said I was just going to go back to Semmelweis, because Semmelweis is incredibly important, and I think provides a very neat example of infection control in hospital a long time ago. This is Semmelweis's, I have to thank my PhD student Jasper Littman for this. This is Semmelweis's original data from the obstetric ward in Vienna Hospital in the 19th century. And I'll just take you very briefly through this. It's very interesting. On the y-axis, we have maternal mortality from puerperal fever, or childbed fever, as they called it then, in the obstetric ward in the Vienna hospital. And we have time along the x-axis here. In the first column here, column A, we have mortality on the ward between 1784 and 1822. You might not be able to read those dates from the back, before they introduced doing autopsies on the ward. Okay, and you can see the maternal mortality rate was relatively low. Between 1823 and 1832, this is column B, they introduced doing autopsies on the ward. And autopsies at that time were done by both doctors, medical students, and midwives. In 1833, this period here, 1833 to 1840, they split the obstetric ward into two sections. One section for midwives and midwifery students, and one section for doctors and medical students. But autopsies were still carried out in both parts of the ward. And you can see here the bottom circle, the filled circle, is the midwifery section, and the one above is the doctors and medical students. But the maternal mortality rate was roughly the same. And then from 1841, they stopped doing autopsies in the midwifery section of the obstetric ward. And you can see the change that happened in maternal mortality due to reduced hospital-acquired infections at the time. A few years later, Semmelweis famously introduced his hand washing. He introduced 4% chlorinated lime, and the rate went down even further and continued to do so after this period in 1850, where the graph actually ends. So a very nice example of simple measures around infection control. Of course, we know now how important they are, but this is, of course, over 150 years ago. Just carrying on the trajectory, we had surgical gloves in 1890, masks in 1897, 1928, Fleming discovered penicillin, sulfonamides and streptomycin followed, and we had further antibiotic developments that led Sir William Stewart, who was the Surgeon General of the United States, to famously say that the time had come to close the book on infectious diseases. That was in 1967. Of course, it wasn't the time to close the book. Fleming, in his Nobel Prize-winning speech in 1945, had already announced it is not, in theory, difficult for bacteria to become resistant to penicillin. And of course, as we know, in the second half of the 20th century, in this trajectory from antimicrobial therapy to resistance, first of all, we had penicillin resistance, and then we've had multi-drug resistant case. First case of MRSA down the bottom here, 1961. Multi-drug resistant TB declared by WHO in 1993 as a global emergency. And just last year, as some people might have picked up in the British Medical Journal and elsewhere, the so-called first completely drug-resistant case of TB in India. So that's just a bit of a historical backdrop. I'm going to focus on the last 10 to 15 years and the role of the HPA. I think I need to tell you a little bit about the HPA and about what we do. It is the national public health body. There are about 4,000 people in the HPA, largely medical, scientific, technical, and nursing. You can see the divisions of the HPA on the left-hand side here. We have about 50 sites around England, and the yellow dots are all our health protection units, teams dealing with outbreaks of infectious diseases around the country, ranging from head lice in schools to meningitis outbreaks, scarlet fever, and of course community outbreaks of various healthcare-associated infections. The white dots are our regional microbiology labs, and the red dots are our national centres. And some people may be familiar with the one down the bottom here in Colindale, HPA Colindale. previously called the Centre for Infections, which has national reference laboratory and all the national experts on various infectious diseases. My own division, Public Health Strategy, is in the bottom left-hand corner. So I said I was going to talk about 3 roles of the HPA around patient safety. They are all indirect, but they have an important bearing around patient safety and HCAIs. And the first of those is surveillance. Now, this slide gives you an overview of the history of mandatory surveillance for healthcare-associated infections in this country. Of course, voluntary surveillance predated this. And please just note in particular around 2005 and 2006, where the arrows are on the green and the red bars, the introduction of MRSA and C. diff surveillance, mandatory surveillance, although surgical site surveillance, which is the light pink, and I'm going to come back to that, started around then in a mandatory way. Voluntary surgical site surveillance started much before that, and I'm going to talk a little bit more about that because it's less well heard of or understood, but I think rather important. As was touched on in the introductory remarks, we look at the trend for MRSA reports on the y-axis over the last 10 to 20 years. You can see the trajectory has thankfully gone down since about 2003, 2004. These are for reports. If you look at deaths from MRSA, those have also gone down in the last few years, the last 7 or 8 years. Now, the light blue and dark blue just indicates there was a change. The chief medical officer asked for a change in clarity around how MRSA was documented on death certification to do with the underlying cause or not. But whether you look at the light blue or dark blue bars, you can see that the trend is in the right direction. Similarly for Clostridium Difficile, these have also declined. Again, we're all pleased about that, from around 2005, 2006. And those pink squares just give you a reminder of the Stoke Mandeville and Maidstone and Tunbridge Wells incidents that caused a lot of attention. And just bringing you a bit more up to speed on both of those, so bringing you up to 2010-11, and we, the HPA, runs all this national surveillance. I know that many of you will be involved in the labour-intensive processes of gathering the data for the surveillance. We oversee, organise, orchestrate the surveillance on behalf of the Department of Health across the country. And this gives you Clostridium Difficile reports on the left-hand side and MRSA reports over the last few years, and the decline has continued. But I said I wanted to mention just something. We're still on surveillance about surgical site infection and surveillance, SSI, as comes up in the slides here. And surgical site infection surveillance, a bit less understood, although we have a number of reports on this on our website, and we use it to influence policy and change. But this has been a voluntary program since about 1997, with 17 categories of surgical procedure. But many hospitals have contributed voluntarily until the mandatory introduction of orthopedic surveillance in 2003, 2004. And you can see in the bottom here, this is the increase in hospitals participating, but also the red line number of operations that have been reported. So there's been a steady increase to 2010, that's the end of 2010 quarter, in the involvement of hospitals in surgical site surveillance. This is, when I say surgical site, is proportion of infections, of operations that are infected around surgical sites. There are 17 categories. Only orthopedic has been mandatory, and this is a so-called box and whisker plot of the different categories of surgical site infection. I know people won't be able to see this, but this is from a very recent report that we've done looking at our surgical site surveillance program. And what I find interesting about this is, despite, just remember, orthopedic is the only category that's been mandatory for a number of years. But actually, if you look where this is on the y-axis here, are the proportion of operations infected by the 17 categories of surgical site infection. If you look here, this is not orthopedic surgery, this is large bowel surgery. The large bowel surgery is the most prevalent. The next box here is small bowel surgery, and then we get coronary artery bypass graft surgery, and it's not till a bit down here that we get hemiarthroplasty and other orthopedic categories. So our analysis in a report we've written on surgical site infection surveillance just relatively recently has indicated that perhaps orthopedic categories are not the best categories to have as the mandatory categories. They're not the most prevalent. And surveillance of these various categories are now being looked at by the Department of Health. That's not to say that we haven't had some interesting findings from surgical site mandatory surveillance. This is the orthopedic, hip and knee. And it's pleasing to see the reductions in hip and knee. Hip is the blue and knee is the orange that's gone on over the last few years. But just look at what's happening down the bottom here, which is a little bit of a cause concern. And if we take, these are the 6 categories of orthopedic mandatory surveillance, just want you to look at the knee replacement proportions of operations, and you can see this is now taking up to 2011. There's been an increase in that. And it's not a big increase, it's a small increase, but it's enough that has led us, useful finding, to be able to take that to ask questions, well, why is our knee replacement operations suddenly having an increase, albeit a small one, in terms of proportion of operations infected? And that's something we've been able to discuss with the Department of Health, with the Royal College of Surgeons, and so forth. So useful findings from the orthopedic category, but I maintain that our analysis has shown it is probably not the most significant of surgical categories. Now that was surveillance. The next way in which the HPA is involved in HCAIs and patient safety, I am calling around prevention. I mean, prevention is a broad term, but I just want to give you the example of our role in prevention to do with the National Point Prevalence Survey that we just point prevalence survey of healthcare associated infections in the country that we recently completed for the Department of Health. And if you're interested, the report is on our website. I'm sure some people will have had a look at some of the headline findings at least already. Now this, just as a reminder, the previous data I showed you were incidence surveillance largely, the number of new cases through a year of, say, MRSA, C. diff, or whatever. The prevalence survey does a different thing. It gives you a snapshot or a picture of the amount of healthcare-associated infection in a hospital, and in all hospitals across the country, in fact, at a given point, or in this case, period in time. It's a period because we did it over a two-week period in 2011. And I'm sure a number of people here will have been involved in the, again, time-consuming data collection that went on for this national survey at the time. Just to put it into perspective again, this was the 4th national point prevalence survey. The first one was 1990, 1993, 2006 was the last. They all differed in their methodology, so it's quite difficult to compare them. Although 2006, as you can see, had the most patients and most hospitals involved. But just hold on to this figure. 2006, 8.2% of patients in hospitals in England at the time the survey was done had a healthcare-associated infection, because I'm going to give you the 2011 figure in a moment. But it was the first time that all UK and EU countries performed the PPS, Point Prevalence Survey, to the same methodology. We led it for the country. We were involved very closely. We developed and provided the training material with ECDC, that's the European Centre for Communicable Diseases, who ran it for the EU. In all countries across the EU, we developed the same methodology so we could compare European countries, because before now, I'd wanted to know, how does England compare with Denmark? How does England compare with France? And although you can look at figures, because everything's collected differently, it's a bit difficult to really compare. But we have performed the analysis the same way for the first time. And the HPA developed all the materials used throughout Europe. The objectives are here, and I just want to steer you to those around the total burden of healthcare-associated infections, and I will give you the results in a moment. The kind of devices used, catheters, intravenous devices, the types of organism, and the AMU, antimicrobial use. This was the first time that the survey had also been a survey of antimicrobial use. None of the other surveys had had that. As I said, the methodology that we developed for all the EU countries. We ran trainer-trainers courses for hospitals and those staff involved in hospitals, the infection control teams. We undertook all the data management. And I think one of the things that we had feedback from hospitals that was very valuable is this here. We provided within 4 weeks, well, and we certainly endeavored to, and I think we hit this with practically all hospitals, an individualized report back to hospitals on the data for their own particular hospital. And some of you, I imagine, I hope, will have seen that data in hospitals, because that was for use by the boards, for use by infection control teams to know where any particular problems were. We had to maintain confidentiality, so we couldn't give to any individual hospital the results of all the other hospitals, but the overall results are, of course, in the main report. And we published that main report just earlier this year, and we're writing up the academic papers now and carrying through the recommendations and actions which I'm going to talk about. But the headlines were that, I can't possibly go through all the details of the findings here. The headlines were, well, first of all, healthcare-associated infection prevalence. That's the top number here, 6.4%. If you recall, I said 8.2% in 2006. So it's gone down. The proportion of patients in hospitals in England with an HCAI at a given period in time, it was a 2-week period, has gone down. It's gone down quite significantly at the face of it. The confidence intervals of these figures did overlap. So although, because they were large samples, we're pretty sure that this is a significant difference, the confidence intervals did overlap. So we have to maintain that in mind in terms of statistical significant difference. You can see that actually the HCAI prevalence varied quite a bit depending on the type of hospital, small, medium, large, teaching hospital, specialist hospital. The rates go up, and this is, of course, because of case mix, more complex cases in general being found, for instance, in specialist and teaching hospitals. Antimicrobial use was 34.7%, meaning that at the point in time, the period in time that we did the survey, 34.7% of patients in England hospitals were receiving an antimicrobial agent. So a third of people in hospitals. And you can see again, perhaps not surprisingly, due to case mix variation, that changes and becomes higher, up to almost half of patients in specialist hospitals. In terms of organisms identified, MRSA and C. diff were down. You can see at the top there the decrease from 2006 to 2011. But hospital infections in terms of the organisms seem to me a little bit like, and a colleague of mine, Mark Wilcox, uses this analogy, like almost like a balloon. The balloon being the total amount of organisms and hospital-acquired infections. And we hope that since 2006 the balloon has shrunk a bit. But what seems to happen is you push one side of the balloon and you reduce MRSA and C. diff, and something else takes its place. And what we found, for instance, is Enterobacteriaceae, always a difficult word in this kind of setting, has increased quite significantly in our findings. Urinary tract infections, E. coli, as examples. So changes in the types of organisms. In terms of antimicrobials prescribed, which is shown on this slide, Please note, first of all, that most of them were for treatment. The yellow bar indicates that they're being prescribed for treatment. But the dark purple is for surgical prophylaxis. And that was one of the key findings and recommendations, was overuse in terms of surgical prophylaxis. I'll come back to that just at the end. Medical prophylaxis is light purple here. The other thing I want to point out to you is Meropenem, which was one of the so-called antibiotics of last resort. I don't use it. I'm also a GP, but it's not an antibiotic that I use very much. But it was the 9th highest prescribed antibiotic. So for an antibiotic of last resort, that's of great concern in the context of antimicrobial resistance and stewardship. In terms of actions and where we're at with that, you can see here that, well, there was an overall reduction. This is actions in terms of healthcare-associated infections. You can see the reduction about 22% in HCAIs, but most of that reduction was MRSA and C. diff. Most common infections, respiratory, urinary tract, and surgical site. It's worth stating, it's important to state, device and SSI, surgical site-related infections, we felt and were felt to be largely preventable. So that's a big area of action. And ICU prevalence was, intensive care unit prevalence was highest. All these recommendations are being taken forward by I and others are part of the Department of Health's advisory group on antimicrobial resistance and healthcare-associated infections, AHI, by the Department of Health. And you can look at all, there are many, many more recommendations on our own report as well. They're all being taken forward and looked at. I've mentioned a couple here. Education and competences of staff and infection control are key. And the shift of thinking from organism to infection. We spent a lot of time over the last decade to MRSA. Actually, it's infections, pneumonias, urinary tract infections. The actions and recommendations from the antimicrobial use side of the point prevalence survey, well, as I said, just under 35%. Often poor documentation of what an antibiotic is being prescribed or an antiviral agent is being prescribed for. Many were prescribed for community infections. Surgical prophylaxis, the guidance about surgical prophylaxis not being used, except for particularly unusual circumstances, for more than a day. Well, you can see there, over 30% were used for more than a day. So that's obviously an area we need to work on. I mentioned Meropenem use. And in terms of actions, well, auditing, benchmarking, start smart, then focus, people will be familiar with. It's going to be, it remains even more important. And hospitals using the data that we provided to work out their own infection control action plans. Electronic prescribing is a priority. Education and leadership is also and stays incredibly important. Now, I've just got one slide on, I said the three aspects of the HPA's involvement, surveillance, prevention, and control. And that's just, I wanted to mention outbreak investigations. Now, we have the HPA has a so-called framework agreement with the NHS. I mean, we are a NHS-like body, but technically we're an arm's-length body. But we have a framework agreement about the support, the work that the Health Protection Agency provides for the NHS, both in community and in hospital settings. And many of our health protection unit, all of our health protection unit teams, I showed you those yellow dots on the map of England, are working on outbreaks of infection control in the community as part and parcel of their daily work. And that includes outbreaks in community, residential homes, and those kinds of settings of healthcare-associated infections. But we also get involved, our local teams, with outbreaks in hospitals. Now, that is not and is never intended to supersede or interfere with infection control teams in hospitals. But we now have a national peer support service with a few of our key national experts, which is increasingly being used by hospitals who have either a particular outbreak that they're struggling to get on top of, or they have a rise, they're noticing a rise in a trend of a certain organism that they're worried about and struggling to get on top of. And I would just urge people that we have, teams of national micro and epidemiological experts that in your hospital, and usually our local health protection consultant in infectious disease control will be on the outbreak control team and the infection control team in the hospital. But some of these relationships work better than others. And I just encourage people, if there's an outbreak, if there's a problem, please do draw on that expertise as appropriate. Key issues.
I'm worried about your next meeting.
Okay, yes, this is my last slide. Thank you for your worry there. Key issues for the future. Well, there are whole-scale changes to the NHS and to the public health systems going on. We've got new organisations, the commissioning board, the local commissioning groups. We've got the Health Protection Agency in April next year will become Public Health England. It is incredibly important that with these changes, with primary care trusts, SHAs going, that we do not lose sight of healthcare-associated infections, both community outbreaks, trends, hospital outbreaks, infection control does not fall under the radar. As I said, there's an awful lot of work going on reviewing the findings from our point prevalence survey. We're reviewing all the mandatory surveillance with the Department of Health that goes on at the moment. We did introduce about a year, 18 months ago, some new surveillance, MSSA and E. coli, as people will be aware of. But we are looking again at all those types of surveillance. And the last thing I wanted to say is on antimicrobial resistance and stewardship. I mean, this is something I am very worried about. It is literally a problem that we are storing up for my grandchildren, and so forth. The likelihood, the possibility that people will be living in a world where what you've taken as a natural access to antibiotics that are available and effective will not be the case. And it is a very, very difficult problem. I don't like to use the word intractable, but it is a very hard problem because although we have to put our own house in order, and of course we need to do all the work from prudent prescribing, it's still the case that whatever we do in this country, we're dependent on worldwide action because resistance crosses borders. So there's more international work that needs to be done to tackle this very, very difficult but important problem. Thank you very much for your attention.